I'm Robert Raw. Welcome to the Regional Anesthesia Study Center of Iowa, or REST. Landmark-based nerve blocks are blind techniques. They utilize surface anatomy to identify the position to insert the needle, the direction to advance the needle, and the plane within which to redirect the needle in. Successful final needle tip position is then confirmed by elicitation of paresthesia or muscle contraction. Best landmark-based nerve block techniques rely as much as possible on fixed bony reference points that are consistent in position between all patients. One should avoid landmarks that are subject to inter-individual variation or to uncertain interpretation. A regional anesthesia standard hand size is 7.5 centimeters across 4 fingers. This is a very convenient measurement basis for many different surface landmark-based nerve blocks. Some blocks use a portion of that distance, such as 3 fingers or 2 fingers breadth. Adapt the rules to your own hand size. This is an axial sectional view of the neck through the level of the 5th cervical vertebrae. The brachial plexus lies lateral to the bony intervertebral foramen and in a space between 2 muscles, scalenus anterior and scalenus medius. This interscalene space lies just underneath the posterior margin of the superficial lying sternocleidomastoid muscle. If the patient rotates their head to the opposite side, typically the sternocleidomastoid muscle will slide around to anterior, letting this interscalene groove come to lie subcutaneous. In this image, the skin has been removed and the brachial plexus is seen lying 2 millimeters behind the phrenic nerve, 1 centimeter in front of the dorsal scapular nerve, and 2 centimeters in front of the accessory nerve. See the interscalene brachial plexus lying in the interscalene groove between the medial and the anterior scalene muscles. In this image, a broken yellow line has been drawn along the posterior margin of the sternocleidomastoid muscle. The lower white line is parallel to the clavicle as viewed here. The upper white line is drawn through the cricoid cartilage parallel to the first. Where the second white line intersects with the yellow line is the point for the nerve block needle to be inserted, according to classical teaching. This, however, has been inconsistent with success. This is because the position of the cricoid cartilage can vary from the C4 level to the C6 level. It has also been shown that simply drawing the second white line 2 fingers above the clavicle is very consistent with success. This works in necks of all sizes and lengths. It is also useful in children and very large adults where their own 2 fingers can be used as the reference distance above the clavicle. The 2-finger rule thus becomes a reliable universal rule. We don't do many nerve blocks without ultrasound anymore, and I only teach it to people who are going to move to circumstances where they won't work with ultrasound. You can have the patient lie supine on the back, head turned away from you. Identify the posterior margin of the sternocleidomastoid muscle. So that's the margin I'm going to mark. Too high. So I like to use bony points as reference points because they're more consistent. I just happen to know a 2-finger breadth is kind of perfect. So I'm resting my hand on her clavicle. I'm measuring 2 fingers above her clavicle. And you'll notice it's a little bit lower than the one I calculated by classic prediction. Someone can have a short neck or a long. The variation in length is above this level. Length varies at not at bottom. It's also handy for children. If I'm going to do an interscalene block on a 5-year-old kid, I will take the child's hands, I'll approximate what 2 fingers of the child are, and I'll use that measurement. You'll notice here she's got an external jugular vein crossing right through the point where I wish to do the block. That is fairly consistent, but don't regard that as a landmark. The external jugular vein is very variable. Do not advance your needle through alcohol wet flesh, because the alcohol burns like... Okay, here comes a little mosquito. And you don't want to inject too deep. You don't want to block accidentally with the lidocaine, which will stop you identifying. Try to avoid a true intracutaneous injection. They actually burn more and they hurt more. Now the next thing is direction of